Okay, chapter 6, we're going to talk about the management of infection. This chapter has quite a few of the little vignettes or little movies in it. I'm not going to show those while I'm talking through the chapters, but I would encourage you, as I've posted the PowerPoint, to go back and look through those. Some of these things that you'll see in the chapters and those little videos we will practice during our integumentary lab. Here is a list of all the videos that are in this PowerPoint. So let's first talk about the defenses the body has against infection. We all carry a number of microflora around on our skin and in our digestive tract. You hear all the time about prebiotics and probiotics in commercials and that kind of thing. As we know more about what lives in our body and what functions in a good way, we also understand when it becomes overrun, what causes disease states. We're going to talk about that a little bit more further in this presentation because there's some things that live in us naturally that don't cause problems as long as we are in a specific state of health. So microflora protect the body from pathogenic organisms. Again, anyone who's ever taken an antibiotic and had stomach troubles from it understand what happens when the probiotics in your gut are destroyed by antibiotics. It just kind of everything runs through you. So they do play an important part in the body. They do make the skin, our pH of our skin is acidic to prevent a lot of bacterial growth on the skin. We have immune cells that attack, the bacteria that try to enter. We have an inflammatory response, which of course we've been through the inflammatory response and why it occurs and how it occurs. And then we have a complementary system which attacks the bacteria. There's a whole series of events that happen as our body tries to defend us against bacteria or a rapid growth of bacteria. This slide talks about the continuum of wound infection, and it's based on what we were just talking about. So as you can see at the top, there's contaminations or colonization. This is normal. So contamination is the presence of microbes on the wound surface. It is normal to have microbes on an open surface. Okay, there is no effect from it. It's also normal can be normal to have replicating microbes on a wound surface. That's colonization. So first they contaminate the open surface, then they start to grow on the open surface. Both of those are normal. It's when the critical colonization occurs, or when there's a replication such that the bioburden begins to adversely affect the wound itself. This is when you start to see the wound decline in status, the wound stops healing. There's so much bacteria on the surface of the wound that the body can't heal. You see the healing process stop. And then when it start to invade viable body tissues is when you see infection. So as you see from the drawings on the left hand side, start with contamination where the microbes are sitting at the top, then they just sit on the surface and colonize, and then they start to colonize even more and replicate more, and then they actually invade the tissues. Again, the effect of infection is a decline in wound status, and you see signs and symptoms of infection, which we're going to talk about more as we go along on these slides. So here's the equation for wound healing. Basically, it's the number of bacteria and the interactions between the microbes, as we saw just a minute ago, the critical colonization of the microbes over the resistance that the body has and what modifying factors they have. So modifying factors, as you see, means how healthy are you overall? What underlying pathologies, such as diabetes or peripheral vascular disease, where you don't have a lot of blood flow to assist in fighting the infection. Maybe there's been a steroid use. Maybe there's non-viable tissue or necrotic tissue or slough where the bacteria can live and breed. Or if there's proper wound management, then that decreases. That is a modifying factor that increases the host's resistance. So it helps that equation on the bottom side of that equation. All right, so what happens when we get a high concentration of microbes on the wound surface? Well, first of all, they compete with the host cells for available oxygen and nutrients, because you think about it, you've got cells that are granulation cells and epithelial cells, so you've got normal healing going on. These cells require oxygen and nutrients just like the bacteria. The bacteria also creates exotoxins, which can be cytotoxic and can kill some of the healthy living cells that are allowing the body to heal and go through the healing process. While the endotoxins that the bacteria create also, as we talked about in other chapters, activate a host inflammatory process. So it can actually keep the inflammatory process going so that delays the body moving through the healing phases because it's stuck in the inflammatory phase. Infections delay and prevent wound healing. So here's some of the factors that increase the risk of infection. You have your host characteristics where there's a break in skin integrity, also known as a wound. That person that has that wound can have diabetes, they can be malnourished, there can be obesity, steroid use, they could be immunocompromised or have an increased age. The local factors are ischemia. Let's say if there's a peripheral vascular disease going on and there's not a whole lot of arterial supply. There can be a high level of necrotic tissue because of lack of debridement. There could be wound debris that's causing the bacteria is living on some wound debris, or it could be simply a chronic wound. Again, as we talked about in the last slide, a chronic wound that's in a chronic inflammatory process that's not moving through that process. So that can increase that risk of infection, and those microbes continue to grow and colonize and infect the tissues. Here's the signs and symptoms of infection. Their cardinal signs of inflammation are, um, temperature and redness and swelling, all of those things. But it's all of those in excess and disproportionate to the size and extent of the wound. So a lot of times you'll ask the question, well, what is the difference between the inflammatory process and wound healing and an infection? Again, it has to do with the extent of the reaction, the signs and symptoms. So as we go through these signs and symptoms, when you're going through the inflammatory phase, you're going to see redness, but you're not going to see redness to the point that you'll see redness when there's infection. You're going to see a little swelling, but it won't be to the proportion that you'll see when there's infection. So all of the signs, the cardinal signs of inflammation, are going to be there, and they're going to be there in a huge way when there's an infection. And also when you see a decline in the wound status. So remember, as you're writing your SOAP note, generally with wounds, we measure them weekly, and we expect to see some movement within 2 weeks. If you don't see movement of that wound or change in that wound within 2 weeks, then your wound is standing still. So you may want to start looking for why. It may signal an infection. That may be the reason that the wound has either stood still or started to decline. So one of the first signs that we're going to talk about is rubor or redness. If it's an inflammation, it's well-defined erythemal border. A lot of times when you're doing wound care, when a patient comes in, you first see them, you'll actually outline. Sorry, I had a little bit of coughing fit there. So when someone comes in with an inflammatory process, you'll outline, take a skin pencil and outline an erythemal border. You want to see, is it getting better or is it getting worse as it pulls in, as the body works through the inflammatory process, you'll see it start to lessen. Whereas if it's infected, there'll be a very poorly defined erythemal border. It'll be a huge amount of redness. And you may see streaking. That's one of the biggest things when you see infection. You see streaking, red streaks coming from the wound. You have to, and going proximally, you have to think infection when you see erythemal streaking. Color is the temperature. When it's a normal inflammation process, you'll see a localized increase in temperature. Again, as you guys get out in the clinic and you start to see people with total knee replacements, perfect example of it. You're going to see a localized increase in temperature around that suture site. If it's infected, there's a huge increase in temperature and it's over the whole knee. You literally, front and back, will see a huge increase in temperature if there's an infection in that knee. And the patient themselves may be febrile. One of the things that we did every single day in therapy when I was in home care and we were seeing total joint patients, patients with a total joint replacement. Every single time we saw them, the very first thing we did was vital signs, and one of those vital signs was temperature, because a slight increase in temperature will give you an indication that there's some infection going on. And it's the quickest way to know that there's an infection versus just an inflammatory process going on. Two more is swelling with a inflamed or inflammatory process. You see a small amount of edema, and it's proportionate to the wound. Again, going back to a total knee replacement, you'll see some swelling right around the incision site. When it's infected, the edema is entirely disproportionate to the size of the wound, and the whole area around the wound, the peri-wound, may be very indurated, very hard, very swollen. Because and you need to think infection when you see that kind of swelling. Dolor is pain. When a wound is just an inflammatory process, there will be pain, but there'll be pain around the wound, right on the incision site, just very localized to where the wound is. When it's infected, there's a lot of pain. If you ask them the pain scale, it will be off the charts. There'll be pain and throbbing, very much disproportionate to the size of the wound or to the incision site. Again, off the charts if you ask them the pain scale, and all kinds of descriptions of pain that is throbbing and won't stop and can't sleep and interrupts sleep, interrupts everything. So it's just a pain that's out of control. You would think infection if you heard that. Functional LASA is the sign that comes with inflammation or infection having to do with ability to function normally. So if you're in the inflammatory process, there may be a temporary decrease in function of the affected area. I'm going to again go back to the total knee replacement. So a patient who has a total knee replacement will have some temporary challenge with range of motion because of the inflammation along the incision site. But if it becomes infected, they literally don't want to move that knee at all. You're also going to see someone who is very sick. You'll see tachycardia, hypotension, altered mental status, and altered function of that affected area. As I said earlier, you'll also see someone who's running a fever with that type of infection. Drainage, when you have an inflamed a wound that's an inflammatory process, you'll see some drainage. It'll be very thin consistency in serous or serosanguinous. Now, serous drainage is clear, maybe slightly yellow. Serosanguinous means it's got a little bit of blood in it, so it's going to be pinkish or blood tinged. Whereas if it's infected, there's going to be a lot of drainage. It will be, again, very disproportionate to the size and extent of the wound. It'll be thick. It'll have a distinctive odor, will not smell good, very purulent, has a creamy consistency. It can be white, it can be green, it can be blue. And as it says, have a distinctive odor. If it is blue, then you know it's a specific type of bacteria. If it's green, the same thing. So any coloration that you see on drainage is, you should automatically think infected. Whereas if it's inflamed, it's going to be more of a clear or maybe a slightly yellow drainage. And it may have some blood tinged, but that's normal. All right, so the decline in wound status, if it's inflamed, it's going to follow the 3 phases of wound healing, just as we've talked about. If it's infected, you're going to see that wound healing stop. There's going to be a plateau. You're going to see a decreased amount of granulation tissue. It's friable, which means that the granulation tissue is very, very fragile and it's easily wiped from the wound, so that you see a loss of granulation tissue. When it says here cobblestone-like, meaning it's not a strong matrix of granulation tissue, and the color does change and it becomes very much more pale. It's not the beefy red that we've talked about with normal healthy wound healing. So here's an example of a wound, and I think we've seen this toe a couple times before. So is this wound inflamed or infected? If you look at the second toe and you see how red it is, and you see the extent of the redness climbing up the toe, it becomes, I think, pretty obvious that this is an infected toe. Also, you see that there's slough, there's dead tissue on the open wound area. So this wound, the redness and the swelling is way out of proportion to that small little opening. Here's another example. Is this inflamed or infected? Well, the sign right there next to it says secondary to infection, so obviously. But let's look at all the different things that we talked about. You can see it's very edematous. You can see that there's a lot of redness around it. Not only around the edges, but if you look at the bottom of it, there's redness that goes throughout. It's probably very painful, and obviously there's going to be a loss of function in this residual limb. And I'm guessing, again, it's warm to the touch. Here's another example we've seen previously. Obviously, the redness, the erythema here is way larger than the wound itself. It covers the whole foot. There's a lot of swelling there. There's a lot of drainage. This is obviously an infected foot. Now, this one is a little bit trickier because we don't see as much, because of the photograph, we don't see as much color here. There's a little bit of redness that maybe we can see, but more than that, we see macerated tissue. We see a red wound bed. It looks like a lot of this is dried, and this does not look like an infected wound. It looks more like maybe it isn't, there's an inflammation process, but it also looks like it needs a good debridement. So I would not say this was infected. I would say that this is inflamed. All right, let's talk a little bit about silent infections. For patients who are immunocompromised or have inadequate perfusion, there's an increased risk for a silent infection. So a lot of times if you're seeing someone in wound care, there may be things going on that if you're not keeping a really close eye out on the wound and what it's doing and how it's healing, then you may miss an infection that has been there the whole time. So examples of this are abscesses, or if a patient has an arterial insufficiency, in other words, they're not getting enough blood flow down there, and they can start to become gangrenous. You really want to look for systemic signs of infection if you suspect silent infection. And remember, some of the systemic signs of infection are fever, malaise. The patient's just not just going to tell you, I just don't feel good. And so you want to do some vital signs and look and see what's going on. Biofilms is something that you'll hear about a lot in a venous insufficiency wound. So biofilms are communities of microorganisms that are attached to the wound surface, and they're encased in a glycocalyx. And so what that means is that there's this coating. It's like a slick coating lies on top of the granulation tissue. It it it's really hard to get off. It increases the bacterial virulence and resistance. So in other words, once you have a biofilm on top of the granulation tissue, that bacteria can adhere to the biofilm and be a little bit harder to get off. It also protects any bacteria against antiseptics and antimicrobials, so it has to be debrided off. It's found on devitalized tissue. It can also be found on implanted devices. Saw a lady who had a total knee replacement, and they literally had to take her prosthetic devices out of her knee 4 different times. They tried to do total knee implants, prosthetics, and every time she would develop a raging infection. So they'd have to open her back up and take those implanted devices out, with the idea that there was something that was living on those prosthetics. As soon as it got into her knee, it would become infected. And the 4th time that they tried it and it didn't work again, she became it with generally within 6 to 9 months that prosthetic device within the knee would become infected, and they'd have to open her up. So the last time they just took the prosthetic device out and just left her open. So she never got another prosthetic device. And they left her open for, I guess it was about a year, just trying to make sure that anything that may be in there, any bacteria was gone before they closed her back up. But she never got another total knee replacement. So, how do we diagnose wound infection? Well, if we suspect wound infection, first thing we want to do is cultures. So cultures are the only way to confirm the presence or absence of the infection, and it also tells us what type we have. The gold standard is a tissue biopsy. They don't often, unless they're in there and see something going on, then they'll do a biopsy. But if you've got an open wound, they're not really going to go in and biopsy tissue if you're looking for bacteria in an open wound. So swab cultures are used to look at how many and the type of bacteria that you find on the surface of a wound. You can also use fluid aspiration and blood tests. Here's an example of aerobic and anaerobic swab cultures. Depending on what you're suspecting as far as the type of bacteria, depends on what type of culture you would do. The lady that I just talked about that had the total knee replacement, and the pieces of the total knee would kept getting infected. Hers was anaerobic culture, hers. So because it was something that was living within her, inside her, it was covered. It was something that could grow without oxygen. So it was an anaerobic bacteria that was inside her, which made it very difficult, much more difficult to kill. And it also was the reason that once they got her open that last time, they just left her open because anaerobic will die in the presence of oxygen. All right, here's how you do an aerobic swab culture technique. So basically, you take the culture and you rotate it over the surface area. You want to make sure that you get some of the fluid from the wound on there. And then you can just swab by making a zigzag pattern across the wound bed. Again, either way, you want to make sure that you're getting some kind of fluid from the tissue on there, and that's because that makes it a successful culture. Then they can see how much of the bacteria and what type of bacteria is growing on that wound bed. So the way that they identify the microbe is once you've done the culture, they look at the shape. Is it round? Is it like a spiral? What does the wound, what does the microbe, what does the microbe itself look like? How does it reproduce? What is it? What is its response to staining? Gram positive is stained by a crystal or violet. Gram negative is sustained by or stained by safranin. And then I already talked a little bit about the environment in which it grows. Does it grow aerobically with oxygen, or does it grow only in an environment without oxygen, an anaerobic environment? Another thing is that bacteria are unicellular. There's only one cell with a rigid cell wall. They have no nuclear membrane, and so they require an external medium for growth. So we talked earlier about colonization and how it gets onto the necrotic tissue and grows. It has to have that necrotic external medium for it to grow, and then it again colonizes, or the cells divide, and that's how the bacteria grows. Another type of microbe which is often found on wounds is a fungi. The most common are skin and nail. Tinea and Candida are two very common types of fungi that you find on the skin and are on wounds. Patients with fungi are often on antibiotics because it can kill as we talked about, the good flora that we have naturally occurring on our skin. The antibiotics can kill that, and so the fungi can take over. Or if there's immune system diseases, any kind of immune system diseases, they'll often have a fungi on them. Diabetics are often at risk for this, and any kind of area that's moist, occluded areas of skin. The majority of times that I've seen this, it's on the leg. It's on a venous insufficiency ulcer where the leg is very wet. On the feet, I've seen a lot of it on the feet. because again they're wet, they're closed up, so it's a high risk for developing a fungi on the skin. Um, So when you're looking at the antimicrobial therapy, so what these antimicrobial agents do is they destroy the unicellular organisms, um, and you can use them to treat an actual infection, or many times a lot of these antimicrobial therapies are used prophylactically. For example, a burn, because you know that you don't have any kind of protection, and you have a large amount of wounded area, a large amount of break in the skin surface. The antimicrobial agent can be used prophylactically to prevent the bacterial growth on a burn. Antibacterials can be bactericidal or bacteriostatic, so they can kill the bacteria, or they can keep the bacteria at a level where it won't grow. Antifungals will also kill yeast and molds. One of the things that I didn't talk about when we were talking about fungals a minute ago, or the fungi that you see on wounds, the first time you see a fungi, it's a white. It's like this white powdery substance that you see all over the foot. I say powdery. It won't come off. It's very white, and that's a common fungi that grows on the, like I said, the lower leg, usually when there's a venous insufficiency or a foot that's very wet. And I think we've got some pictures of examples. All right, so types of antimicrobials, you have your penicillins and your tetracyclines, and there's a list here. All of these, of course, are prescribed by the doctor, and once you do your swab, your culture, depending on the type of microbe that's growing on the wound, the doctor will then prescribe the specific antibiotic that kills that type of microorganism. If a bacteria is sensitive, it's unable to grow in the presence of that antimicrobial. If it's resistant, the bacteria will continue to multiply. And that resistance can be natural. In other words, it just doesn't, that particular antimicrobial doesn't touch that bacteria at all, or it can be acquired. So that if that antimicrobial has been used with this bacteria for so long that the bacteria has required resistance to it. This is where we talk about using antimicrobials and antibiotics in the way that they should be used, so that they're used throughout the whole process, meaning that every bit of the bacteria is killed, so that you're not creating this resistance. So that's why it talks about here premature cessation of antimicrobials and misuse or overuse of antibiotics increases the possibility of resistance. So once it's started, all of that bacteria needs to be killed. It needs to be used until all of the bacteria is killed, so that you're not creating this resistant strain to that antibiotic or antimicrobial that you're using. All right, so now we'll talk about a few types of resistant bacteria. One of the most commonly known is MRSA, methicillin-resistant Staphylococcus aureus. You can get it in the hospital, meaning nosocomial, or it can be acquired in the community. Those in the hospital we see that acquire MRSA usually have an increased age, they're diabetic, they're immunosuppressed, malnourished, they may have had a recent surgery, they have immobility or they're debilitated, large burns, or they had prior antimicrobial use. In the community, it's often acquired where you see a lot of people together, such as prisons, contact sports, military, or people, again, with AIDS who are, in the community, immunosuppressed would be AIDS. Otherwise, it's where you see a lot of people very living in a very close proximity, such as prisons, military, and then in locker rooms, there's been a lot of publicity about it occurring in high school locker rooms because, again, the cleanliness, I guess, is not always as good as it should be, and it gives this bacteria room to grow, and then it spreads amongst the population because they're so close to each other. So the other thing about MRSA is it can live hours to days on surfaces, again, which is why when you're talking about it in the community, if the cleanliness is not there, if things aren't wiped down, it can live long enough to infect quite a few people. It can be spread by environmental contact in the nosocomial situation or from person to person in the community situation. MRSA can cause cellulitis, osteomyelitis, and abscesses. The treatment for it is mupirocin, which is the type of antibiotic. VRE is vancomycin resistant endococcus. This VRE is most commonly seen, well, it's not seen in the community at this point. It's only seen in a nosocomial situation. But it's commonly seen in surgical wounds and with urinary tract infections. The treatment for it is ampicillin or amoxicillin. One of the most important things to remember is that although we're hearing more about resistant strains, so they are becoming more prevalent, they're not becoming more resistant. Okay, so that means the resistance in these strains has not changed. They're just as resistant now as the first time we saw them. The problem is that we're seeing them more and more. So it's not that there's been a change in the resistance. It's just that we're seeing more of these resistant strains occurring in more people. So we talked about a little bit about this. This was one of the slides we saw earlier. But some of the causes of resistant bacteria is the misuse of antimicrobials in humans. 50% of the antimicrobials are deemed unnecessary. They're prescribed without an infection present. I have seen in my years doing wound care when there was other things going on within the wound, and the physician would prescribe an antibiotic, which was not always necessary because, again, there really wasn't, there was an inflammatory process, there was a delayed inflammatory process, but there wasn't necessarily an infectious process. So that's kind of some of the problem we see with increasing the amount of resistant bacteria we see. Again, not that the bacteria is more resistant, but we're just seeing more of them. Or if the wrong antimicrobial is prescribed, if there's not a culture done and the physician's just kind of guessing at what microbe he's working it with, and they prescribe the wrong antimicrobial. Or again, if it's taken incorrectly. So, someone takes it for a day or two and says, oh, I feel better, my wound feels better, I'm getting around better, it's not as swollen, so they stop taking it. That can, again, cause a resistance in the bacteria because not all of the bacteria is gone. So what you do is you develop a more resistant bacteria. Other causes of resistant bacteria are the misuse of antimicrobials in animals. 24.6 million pounds of antimicrobials, antibiotics are used in livestock per year in the U.S. Because the farmers found that when they used antibiotics and antimicrobials in all type of livestock, that the livestock would build muscle faster. And so also when you think about the environment in which livestock live, it's kind of like we talked about earlier with the MRSA. This is extremely crowded, lots of animals. The use of antibiotics prophylactically kept them from getting sick. But it's a misuse of an antibiotic or antimicrobial in animals, and it has been banned in the European Union. It's not yet been banned in America. I don't know that it will be, but I guess as we see more resistant bacteria, it may be something that we look at doing here. So this is an a adverse reaction. So a systemic adverse drug reaction that you might see, an ADR's adverse drug reaction that you might see with an antimicrobial. You see them less frequently with systemic antimicrobials than you do with topical agents, but when you see them, they're more severe. So someone who reacts to a systemic antibiotic or antimicrobial is going to have much more severe reaction than someone who reacts to a topical. A topical reaction is basically, as it says here, mild skin reaction or hives. When you're talking with someone who has a adverse drug reaction with a systemic antimicrobial, you're gonna see difficulty breathing. You can see anaphylactic shock, photosensitivity, hearing loss, fever, kidney damage. There's it's usually more severe on a systemic level than it is than if it's a reaction to a topical. The most common adverse reactions that you'll see are to penicillin or sulfa drugs. Those two antimicrobial antibiotics are the cause the most common adverse drug reactions or ADRs. You may see a delayed sensitivity to neomycin, gentamicin, bacitracin, anything containing lanolin. Lanolin comes from sheep, and sometimes there's a reaction to that, a delayed reaction to that. So the person may have been using maybe a cream or a moisturizer over a period of weeks, and then all of a sudden they start to see a reaction. It may have been that delayed reaction to that lanolin. The main thing is you don't want to use these for prolonged periods. Also, the gentamicin, if you've not heard this yet, the gentamicin is ototoxic, so it does kill with prolonged use. It does kill the vestibular cells, the hair cells in the vestibular system. And so it's really important when there's a use of gentamicin that it's really short term, and that your patient will be tested. They'll do audiological studies with anyone who has to be on gentamicin. They'll do audiological studies to make sure that the vestibular cells aren't being killed, because gentamicin is ototoxic. All right, so what can we do as far as when you know someone is on an antimicrobial? Make sure that that patient, you talk to them about, are they taking their drugs as they're prescribed? You really want to educate them. You want to talk to them about why is it important that you take your drugs as prescribed. You hear so much of this nowadays, but you don't always know that your patients are hearing that or they're heeding it. So you want to make sure that you educate them about how they're supposed to, quiz them on how often they're supposed to take the drugs and how they're supposed to take the drugs, and make sure that every time you see them that they're taking them as prescribed. Talk to them about any signs and symptoms of adverse drug reaction. Make sure there's nothing going on, or the patient may think, oh, it was nothing, my tongue just felt a little fuzzy, or got a little bit of a rash or something like that. They may think nothing of it. But make sure that if you hear that, you're questioning them about that, make sure that you immediately let the physician know. So you want to always observe for signs and symptoms of an adverse drug reaction, and if you see them immediately, especially if we're using a topical and we see any kind of reaction, you want to stop the use immediately and call the physician and let them know. So, some of the types of topical antimicrobials, they come in ointments, creams, and solutions. They're applied to the wound surface and they're reapplied every 8 to 24 hours. So, antimicrobials are not something that you can do once and then they come back 3 days later. These are something that are done daily and then sometimes twice a day. Um, There are antimicrobial impregnated dressings. When we go through the different types of dressings, and I'm going to bring some when I come to the integumentary lab so that you can see them. But some of the dressings are impregnated with silver and iodine. There's broad spectrum antimicrobials. Anytime you use this type of dressing, which um, about 5 years ago, the use of silver and iodine in dressings just absolutely went crazy. It increases the cost. It may contribute to resistance. It has to stay in contact with the wound bed for it to be effective. And the research shows that the antimicrobial impregnated dressings really don't have any advantage over good wound care. So again, they increase the cost, but there's a lack of scientific evidence that they're cost effective, really, because there's really no reason to go to that kind of expense. Now, you know, the people who of course make these dressings, again, they get more money for them. So when you listen to any of the reps that come in and sell these kind of dressings, they're gonna tell you something different. But the evidence-based research says that there is not a difference with using these dressings versus using good wound care. The advantage with a topical is that it's a lower cost than a systemic therapy. So someone who's on a systemic, an IV of antibiotics, of course, they have to be in the hospital because they have to be watched for an adverse drug reaction. So right there, that the topical, you don't necessarily have to be in the hospital. You can get wound care on an outpatient in an outpatient setting and use a topical antimicrobial, but you could not get a systemic therapy or an IV of antibiotic in an outpatient setting. The antimicrobial will also reduce the bacterial load directly on the wound. Now we talked about the wound, how the bacteria grows on the wound, so using a topical will reduce that bacterial load directly on the wound. And it's also effective when you're treating a wound where the circulation is compromised. So if there's an arterial insufficiency, you can put an antimicrobial on that wound bed and it will help decrease that bacterial load, even though the circulation, you don't have a lot of perfusion there, you don't have a lot of help from the body in fighting that bacteria. The disadvantages is that, again, it's higher cost than a non-antimicrobial. You have to put it on more frequently. Earlier we said 8 to 24 hours, so they're being seen at least twice a day for dressing changes. You can see patients that are sensitive to it or have an allergic reaction. And if it's used inappropriately for a long term, you see a potential for resistance of the microbe to that antimicrobial that you're using. You want to, the correct way to use a topical antimicrobial is to use it only when there's infection. If it's simply an inflammatory process, you don't want to use an antimicrobial. You will see that mistake made a lot of times in long-term care facilities, is that an inflammatory process or a delayed inflammatory process is mistaken for an infection, and an antimicrobial is used for, a topical antimicrobial is used for a long period of time. So you want to stop when the signs and symptoms of the infection resolve if there truly is an infection. The exceptions are for prophylactic use. So those who are at increased risk for infections, such as someone who's immunocompromised, if there's a grossly contaminated wound, or if you have a non-healing pressure ulcer. Oftentimes there would be a 2-week trial. For some reason, if there is a if there is a colonization or a critical colonization on a pressure ulcer such that it stops the healing, then you can do a 2-week trial of an antimicrobial, topical antimicrobial, and it'll kind of jumpstart that pressure ulcer to start healing again, because it decreases that bacterial burden on the wound surface, and so that the wound will start to heal again. So this is an example, and again, you've seen this picture a number of times, but if I can find, let's see, there we go. Right there, if you see those beads right there, those are antimicrobial impregnated beads that are put in, surgically implanted in the wound. They're left there generally for about 3 to 4 weeks. And then the surgeon or the physician takes them out, um, within the hopes that it has killed any of the microbes within, deep within this wound. So what you can't see here, and by the way, this is an example of fungi right here. All of this white that you see, is an example of a fungus on this wound. But these antimicrobial beads that you see here, are implanted deep into the wound surgically. So because we can't see the top of the wound, couldn't see that. Okay. Here's the correct way to apply a topical antimicrobial. So first of all, when you want to make sure that you've got the right antimicrobial for the right patient. You also want to make sure that the expiration date on the antimicrobial is not expired. A lot of times if these antimicrobials are used for a long period of time, you will see expired, they will send down expired drugs that you of course don't want to use. So as you read through this, number 5, it talks about changing your gloves frequently. I've talked about this before, but it is really important that you change your gloves frequently. And then when you get to number 6, the most important thing is you always use a sterile surface to apply either the ointment or the cream, or if you're squeezing out of a tube, it must be on a sterile glove or a sterile applicator, and you never reach back into that cream or that you never reach back in to get more with that same sterile surface. The sterile surface is only sterile once. So if you put some on a sterile glove and you rub it on that wound, that glove is no longer sterile. If you need to get more, you need to get another sterile glove, because that glove is no longer sterile. So it's really important when you're applying these antimicrobials that you be very, very careful with this, how sterile your surface is. All right, here's a couple of antiseptic agents. So they prevent infection by killing the microorganisms. In earlier lectures, I had talked about Dakins, which is basically bleach and water, and acetic acid. There are 2 types of antiseptic agents that are often used. Betadine is another solution that's often used. So these should be used as a surgical scrub or for hand washing or cleansing intact skin. These should not be used on open wounds. Now, Oftentimes you will see Dakin solution used on an open wound. If it's severely infected, usually I've seen it used if it's severely infected with feces. And that's because if you use it for a short period of time, not longer than 3 days, it will kill any bacteria that you've got growing in there. But if it's used longer for than 3 days, that's an inappropriate use of an antiseptic agent because it will also kill immature epithelial cells. It will decrease your granulation tissue. So it is really, it'll kill the good cells as well as the bad cells. And so Dakins should be used no longer than 2 to 3 days tops. And betadine, providone iodine, should never, ever, ever be used on an open wound. It should only be used on intact skin for cleansing or hand washing. They're cytotoxic. I just talked about this. They're cytotoxic. They increase the duration and intensity of the inflammatory process. They slow wound healing. And again, in rare cases, it may be appropriate for short-term use on open wounds. 2 to 3 days tops, should be no more than that. Systemic antimicrobial therapy, such as antibiotics, the physician often prescribes these for sepsis or signs of an advancing infection. A lot of times, if you see you see a patient that has gone from especially in the foot, you see a wound that goes from cellulitis to osteomyelitis, you'll see the physician will then start prescribing a systemic antimicrobial. They'll put them in the hospital and they'll hang an IV of antibiotics. Osteomyelitis, as I said in earlier lectures, is really difficult. It's really, really, really difficult to kill bacteria and microbes once it's in the bone. So almost always someone with osteomyelitis will be on a systemic antimicrobial therapy. So they may be used with or without a topical antimicrobial. So in other words, you may be seeing, if it's an inpatient setting, you may be seeing the patient for wound care and they've got a bag of antibiotics hung, so they're getting an IV at the same time that they're getting a topical antimicrobial. It says it may be administered intravenously. Sometimes you will see patients that are taking them by mouth, but generally that's towards the end of the episode. Initially, when they started, especially if it's because of sepsis or osteomyelitis, it's going to be IV. The advantages are it reduces the bacterial load. It's easy to provide, and you have better, especially if it's IV in the hospital, there's better adherence because the physician and the healthcare staff is controlling the dosage and controlling when you take it. The disadvantages is that you do see severe adverse reactions. We talked about that earlier. There can be a resistance that's formed with systemic antimicrobial therapy. If they're taking it by mouth, if there's missed doses, then that's going to cause more of a problem, more of a resistance problem. And again, it costs much more. It costs so much more to do a systemic antimicrobial than it does to do a topical. We talked about debridement in an earlier lecture, and I talked about it's incredibly important to prevent infections. It reduces the bacterial bioburden, increases the effectiveness of the topical antimicrobials and antibiotics, and then, of course, it must be performed by certified personnel, so people who have been trained in debridement. Surgical debridement is only done by a MD or a podiatrist, but it is commonly used for an infection that's progressing pretty fast. If there's an area of decreased perfusion, so you don't want to do a clinical debridement, you want to get that area of decreased perfusion, the necrotic tissue out of that area that doesn't have good blood flow, or if there's osteomyelitis or sepsis, in the area, then the physician will generally go in and do a surgical debridement, and they'll follow it by antibiotics. And generally it's called an I&D, or an incision and drainage. Those are often done with abscesses as well. A lot of times an I&D is done if you'll see a polynoidal cyst, which is in the coccyx area. The physician will go in and do an irrigation and a drainage, or if there's abscess anywhere within the body, they'll go in and do an I&D. So there's only a few microorganisms that are responsible for the majority of wound infections, and that's why when we only talked about the MRSA, MRSA methicillin-resistant Staphylococcus aureus, or the VRE, the vancomycin-resistant Enterococcus. It's because there's not a whole lot. There's staph, there's strep. There's not a whole lot of microorganisms out there. So it's actually pretty easy to, with a culture, to recognize what it is. And once it's recognized, the correct amount of or the correct type of antimicrobial therapy can get rid of it. That's basically what this is saying. So what you want to do with someone who has any kind of comorbidity going on is that they have to manage those medical conditions. I've talked a lot about diabetics and the number of diabetics I've seen in the past. Those blood sugars have to remain as close to normal as possible for a patient to heal if they're a diabetic. Patients who have wildly swinging blood sugars you're not going to see wound healing in them. So you have to manage the medical conditions known to increase the risk of the wound formation. Otherwise, you're going to see the wound get bigger, and there's going to be a decrease in healing. It's important that you position the patient properly. There's proper skin care, and then especially for diabetics, there's proper foot care. One of the best ways to prevent infections and open wounds is hand washing. You have to be really, really diligent about hand washing and changing your gloves and making sure that you're keeping that environment as clean as possible, using universal precautions and standard precautions with all of your patients. So this is, we're going to go through, there's a couple of videos here. Again, I'm not going to show them, but this one is the proper way to wash your hands. This is the proper way to use a hand sanitizer. This is the proper way to don clean gloves. Now, we will practice this for Integumentary Lab, but I do recommend you watch this video about how to don clean gloves. This is how to put on a cap. And this is how to put on a gown. This is donning a mask. And this is donning protective eyewear. So let's talk a little bit about clean versus sterile technique. Clean technique is when you want to reduce the number of microorganisms present to decrease the risk of transmission. Clean technique can be used, it's a standard. It can be used in any hospital room. It can be used in any home setting. Clean technique can be used anywhere. Sterile technique is when only sterile equipment contacts the patient's wound. Sterile technique is used when you're packing wounds, when you've got large surface area wounds, when you're treating somebody with severe burns or immunocompromised patients. Sterile technique is used in a sterile environment. Clean technique is used in any environment. So let's talk a little bit about contamination is the presence or anticipated presence of blood, wound fluid, or other potentially infectious waste. Clean means it's free of gross contamination. Disinfect means to clean a surface with an antimicrobial. And sterile means the environment is free of microbes. This is really important that you understand a sterile environment means it's completely free of microbes. The only areas that we know of that are sterile are the negative pressure rooms, where they do surgeries and that kind of thing. Those are sterile environments. So let's talk a little bit about contaminated. So if you are seeing a patient, most of the surfaces in their hospital or in any kind of facility are contaminated. You can wipe them down with an antimicrobial agent. For example, if you've ever been in an outpatient setting, most of the time they wipe the mats down with some kind of cleaning fluid to clean it. If you wipe it with a antimicrobial, you'll disinfect it. But sterile can only be in an environment that is completely free of microbes, such as a negative pressure room. That is a sterile environment. Here's a video on donning sterile gloves, which is different than donning regular gloves. So it's really important that you watch this video. We may or may not be able to practice this. I don't know if we'll be able to get sterile gloves, but I'm going to ask that question because sterile gloves are a little more difficult to don because you have to make sure that you keep that sterile environment. And so the way you put them on is very specific. So please watch this video. This is how you maintain a sterile field. This is how you open a sterile kit. This is if you forget something and you have to add an item to a sterile field, this is how you do it. This is how you add a solution to a sterile field. Okay, let's talk a little bit about proper wound care procedures. These are all things that we've talked about before. You always want to check your expiration dates. Now, when I say expiration dates, I mean on your drugs, on your any of your supplies you're using, because all of the supplies are also, they also have dates on them and they do expire. So when you say, well, how can a Q-tip expire? A Q-tip is considered sterile for only a certain period of time. So please make sure when you're using supplies, you look at the dates on the supply, and if it's expired, you do not use it because you cannot know that that is sterile equipment. That's then a sterile supply. Open the supplies only that you need and immediately prior to when you're going to use them. Any other supplies you want to make sure that they remain sealed. The meds have to be stored according to Joint Commission standards. 9 times out of 10, unless you're in a wound clinic, you won't have meds in your clinic. Keep the wounds covered at all times, except when you're doing an examination or you're doing a procedure, and change the dressing if it becomes contaminated or ineffective. If you see a dressing, let's say you do a dressing change on a patient, and before they can even get out of the clinic, it looks like it's soaked through or something, then you need to change that dressing again, and you need to try another type of dressing to make it more effective. Sequence the wound procedures to minimize the contamination. Now, what that means is that, for example, you would do any kind of debridement that you needed to do first, okay? You would first take the old dressing off. You would then clean the wound. You would then do your debridement. You'd then clean the wound again, put any kind of topicals or whatever you need on it, and then put a clean dressing on it. So if there's multiple wounds, you want to treat the most infected wound last and change gloves in between the wounds. If you think about it, if you treated the most infected wound first, then any of the wounds you treat subsequent to that, you have a higher risk of infecting them. So you always want to treat the most infected wound last. We've talked about removing gloves and washing your hands when you finish. Change your gloves frequently. Thoroughly disinfect the treatment area and dispose of infectious waste and sharps.